Hello, dear colleagues. My task today is to talk about the perimetry in glaucoma. This is the disclaimer slide. Glaucoma is defined as an optic neuropathy associated with characteristic structural damage to the optic nerve and visual field that may be caused by various pathological processes. And the most consistent of these is elevated intraocular pressure. Glaucoma diagnostics consists of several steps. And although we nowadays have modern imaging methods like the HRT or OCT, perimetry still has an essential role in the diagnosis and follow-up of glaucoma because it's the only method that tells you what the visual functions of your patients are. Perimetry in glaucoma should be static perimetry with a wide achromatic stimulus size 3 and a threshold or fast threshold strategy. Kinetic perimetry or the examination of the central 10 degrees or the use of a larger stimulus is reserved for advanced glaucoma. But is there anything else that can be tested in your glaucoma patients? Yes, some advances have been made in the perimetry of glaucoma, and they are reflected in the newest perimeter of the size. It's called Humphrey Field Analyzer 3. And you can make use of these new features either after an individual test or when evaluating the progression in your patients. After each perimetry test, you can look at the single field analysis. And when you have performed several tests, then you can evaluate the progression analysis or the GPA. Let us first look at the single field analysis in detail. Out, you can find the reliability indices. Of all these indices that tell you how valid this particular examination was, the rate of the false positives is most important, and their rate should not exceed 15%. Further in the printout, you find the threshold values measured in your patient, either in decibels or coded in a grayscale map. I'm afraid most doctors look at this part of the printout when evaluating their patients, but this is enough if you have a patient with hemianopia, for instance. In a glaucoma patient, you should always check the graphs in the lower part of the printout. There you find the total deviation decibel plot, which compares the threshold measured in your patient with the age-corrected values, and this difference is displayed in decibels. In the total deviation probability plot, this deviation is assigned a statistical significance. So, if a black square is displayed at a particular location, it means that less than 0.5% of the population has such a difference at that point. Both graphs on the right side of the printout have the same meaning with one difference. The generalized depression in the visual field, which is usually caused by cataract, was removed, and so a localized visual field loss is more obvious. And these localized defects are typical for glaucoma. This is a practical example. On the top, you have a patient with cataract and glaucoma, which is a condition quite usual. And there on the left side is the total deviation probability plot, and this is the pattern deviation probability plot. And this graph tells you what the damage both from glaucoma and cataract is. And here you see the damage of the visual field caused only by glaucoma. So in a patient who only has glaucoma, both graphs are equal. And like this, you can evaluate which part of the visual field damage is due to glaucoma or cataract. When you have performed several tests, you can go to the guided progression analysis, or the GPA, where the progression analysis is summarized. Progression analysis can either be a so-called event analysis, which tells you whether progression has occurred or not, or it can be a trend analysis, which tells you how fast this progression was. The event analysis in a Humphrey perimeter is called glaucoma change probability map, and it tells you whether progression is likely or possible. The trend analysis, as I said, informs you how fast this progression was. And for this trend analysis, you can either use the MD index or the visual field index. The visual field index is unique for the Humphrey machine, and it expresses the visual field of your patient as a percentage of a healthy visual field. So a healthy person with no visual field defects has a visual field index of 100%, and a perimetrically blind person has a visual field index of 0, and your patient may be somewhere in between. And if you plot this visual field index on a time axis, then you can observe how your patient is doing in long term and what his prospects are for the future if this trend continues. Why should we actually evaluate the rate of progression? It's because every glaucoma progresses, but the question is how fast the progression is. Without treatment, we are trying to save the visual functions of our patients as long as possible. And in terms of visual field, we want to prevent a significant visual field loss under -15 dB, which was defined to significantly reduce the quality of life in glaucoma patients. So if you then look at this trend analysis and have a patient like here on the left, who is progressing slowly and will probably have good vision by the time he's 90, then you can sit back and relax. But if you have a fast progressing patient like this one, who may get in trouble by the time he's 60, then you should do something about his treatment when possible. And it was found that it is important to define these fast progressing patients soon after the diagnosis. And in order to do this, you should test more frequently the visual field. In particular, you should perform 6 visual fields in 2.5 years. Because if you do the test only once in a year, then you don't know how to intersect the line. If you do more visual field tests, then you can lay the line easily with a narrow confidential interval. I have an example here of a patient who was diagnosed with such a visual field defect in one eye. And as you can see, I performed then the visual field test every half a year so that I can see if my treatment was effective. Because all this I was talking about, these 6 visual fields in 2.5 years, implies for patients who have a visual field defect at the time of diagnosis. These are most at risk. And I know the information of 6 visual fields in 2.5 years may easily be forgotten, so I found a slide that might help you remember this information, and I hope you like it. Well, I just told you that you should do more tests, but this takes time, and there are many people waiting outside of your office, and you certainly have other interests in ophthalmology as well. So what you need to do now is speed up. And I'm going to show you how you can speed up with the Humphrey Field Analyzer 3. You can use the 24-2 test, use SITA faster, and test central 10 degrees simultaneously with SITA faster 24-2C. 24-2 test has less points in the periphery compared to the 32- test, except for the nasal region, so that it takes less time to test, and also it has less rim artifacts. But on the other hand, the detection of a nasal step is preserved. So you can easily take this test for your glaucoma patients. SITA is an abbreviation for Swedish Interactive Threshold Algorithm, and it is a fast threshold strategy which determines visual fields in a more efficient manner. It optimizes the determination of perimetry thresholds by continuously estimating what the expected threshold is based on the patient's age and neighboring thresholds. And like this, it reduces the time necessary to acquire a visual field, and it decreases patient's fatigue and increases reliability. The trend towards the development of faster strategies is obvious from this slide. As you can see, SITA standard, which was released in 1997, took half of the time of the full threshold test, and the latest SITA faster takes only 1/5 of the full threshold test. And if we look at the times in minutes, then SITA standard lasts 5.5 to 10 minutes per one eye, whereas SITA faster only 1.5 to 4 minutes. Of course, the duration of the test always depends on the cooperation of the patient and the degree of visual field loss. What makes SITA faster? First, it's smarter starting values at 4 primary points. Then one staircase test sequence is performed at the primary points instead of 2. SITA faster visual field model uses the distribution of SITA fast normal values, whereas SITA standard and SITA fast had to take the normal values from the full threshold test. Further, no retesting at perimetrically blind points is performed, and an extra 300 milliseconds delay after non-seen stimulus was eliminated. The very important false negatives and blind spot catch trials are no longer performed. Let's look at some of these changes in detail. You save time already at the beginning of the test because the starting values at the 4 primary points are age-corrected normal threshold values, whereas in the other tests, it's always 25 decibels. False negatives are no longer registered because it was shown that the rate of false negatives is higher in glaucomatous visual fields. It's simply a property of the visual field, and the patient can do nothing about it. Like in this patient of mine, who has 0% of false positives, but the rate of false negatives is 14%. It's simply a property of his damaged field. Also, the Heijl-Krakau method was replaced by gaze tracking. In the original fixation control method, the stimuli are displayed repeatedly on the place of the presumed blind spot. But just if the patient moves his head a bit, these stimuli may fall outside the region of interest. And so the fixation control is not precise anymore. So in this new program, this method was replaced by gaze tracking, and you can check it at the bottom of the printout. SITA faster was tested in a multi-center clinical study and showed that it can save considerable test time. It gave almost identical results as SITA fast, and there were only small differences between SITA faster and SITA standard of the same character as previously shown for SITA fast versus SITA standard. The last thing I would like to talk about is the central visual field in glaucoma. The usual idea of visual field progression in glaucoma is that the central visual field is spared until late in the disease and a concentric visual field loss develops. But is the center of the visual field really intact? I performed a study on pupil perimetry in glaucoma some years ago. We used the stimulus pattern that you can see on the left, and the intensity of the pupil light reaction is displayed by the height of the red column. And as you can see, in the lower part of the visual or the pupil field, these red columns are smaller than in the upper part, and it corresponds to the visual field effect of this patient with glaucoma. And when we compared the pupil light reaction in glaucoma patients and healthy subjects, we found a significant difference at all tested locations in the visual field. But the greatest difference was in the center of the visual field, which does not really correspond to the classical idea of visual field progression in glaucoma. And at the same time, Dr. Hood published a study showing that glaucomatous damage of the macula occurs and can be revealed by OCT. But the problem is that the raster of the current perimetry tests falls outside this region of interest. It's simply not dense enough to detect this glaucoma damage in the macula. He also designed a chart showing that the lower part of macula is more vulnerable to glaucoma damage. And that is why you more often get a patient with an upper paracentral defect than with a defect in the lower part of the hemifield. So as you can see, glaucomatous damage of the macula can occur. It can occur even early in the disease, and it can be missed or underestimated with standard visual field tests that use a 6-degree grid. But on the other hand, it would be redundant to perform a 10-degree test on top of a 24-2 test in all of your patients. So with the SITA Faster, you have the possibility to use 24-2C pattern that combines all 24-2 points with 10 selected 10-2 points. And so like this, you can test both the periphery and the center in one go. And then you can maybe get a patient like this who showed no changes with the 24-2 SITA standard, but when retested with 24-2C SITA Faster, some significantly depressed points in the paracentral region showed up. Well, as you can see, there are modern methods or very sophisticated methods how to examine your patients with glaucoma. But I would like you to remember that perimetry is still a subjective method. The result always depends on the motivation and cooperation of your patients and the conditions for the test. So please have this on your mind. I hope my talk was helpful for your perimetry practice, and thank you for your attention.